Hello, everyone. Welcome back for day 2. We are so excited that you are here to join us. We hope that yesterday that you got a lot of insight and were able to network with like-minded people. I know I learned so much in the sessions that I was able to moderate on stage. We are so thrilled to have you back, and we have Dr. Perez, who will be joining us shortly. First, I just wanted to give a shout out to our sponsors. We could not put this on without them. Here we are. So Prolacta Bioscience, it is changing the lives of critical ill infants worldwide. All Prolacta provides are proven in all products are proven to improve health and reduce complications. And please go to prolacta.com/en for more information. And just personally, they have been helping with our scholarship program by helping with grants with that. So, all right, without further ado, I would like to introduce, I'm going to bring her up. Here is Dr. Perez.
Hello, so excited
Welcome,
to be
everybody. Here. Yes, we are so excited to have you. Let's see, one second. Okay. She is on the board. She's been with us on the board for about a year now, and we're thrilled to have her. So Dr. Perez, Ph.D., studied public health, specializing in community health and education, and is a registered nurse working with neonatal and pediatric populations. Her current position is a National Clinical Improvement Thought Leader NICU for Philips Healthcare, where she identifies gaps in the NICU space and develops clinical services to improve the overall quality of care through education and change management, including family-centered development care. Dr. Perez serves as a member of the Board of Directors for Infant Massage USA, has quantified and quantitative research publications, and was co-author of a public health policy to expand postpartum care. Her presentation topic will address the opioid epidemic in the U.S. and how it has caused withdrawal symptoms in newborns, known as neonatal opioid withdrawal syndrome. This research study explored the process and experiences of implementing infant massage as a standard practice for NICUs to inform national, state, and local policies. So, thank you, Dr. Perez.
Thank you. I'm really happy to be here today and talk about babies with neonatal opioid withdrawal syndrome and my study findings. Oops. Okay. There we go. So the agenda, I'm going to go over the prevalence of neonatal opioid withdrawal syndromes, what it is, the public health response, infant massage and babies withdrawing, and then I'm going to go into my qualitative research study findings. So unfortunately, even the last 2 decades, there's been a fivefold increase in misuse during pregnancy. It was reported in 2017 that 1 in 4 women on Medicaid filled prescription for opioids, and 1 in 5 women on private insurance filled prescription for opioids during the pregnancy period. This is causing the chronic exposure to opioids in utero causes withdrawal symptoms after birth. Since the 1970s, we've known this as neonatal abstinence syndrome. But the FDA found that the majority of these babies with withdrawal symptoms were a result of opioids. So they made the terminology neonatal opioid withdrawal syndrome. However, for 45 years, there's been no actual clinical definition of what that means. And just last year, the HHS worked with healthcare professionals, and they have developed standard clinical definitions for neonatal opioid withdrawal syndrome. Different from neonatal abstinence syndrome, neonatal abstinence syndrome can be any substance, where neonatal opioid withdrawal syndrome is just with a history of opioid misuse. So currently, 6 to 20 births per 1,000 in the US are babies exposed to opioids. Unfortunately, there's also states, example, Vermont is over 40% per 1,000 in the US. So the rates of babies withdrawing from opioids varies depending on the state currently. So the public health response to NOWS is really important because it's causing $1.8 billion in annual healthcare expenditures and $2.8 billion a year in child welfare, just as a result of babies with neonatal opioid withdrawal syndrome. So we really need a public health response. There has been a series of public health policies beginning in 1974 is the first one for child abuse and prevention. This was just giving guidance on abuse and neglect. In 2015 was when there was a report written, Perinatal Drug Use and Newborn Health. This is when there was an understanding that this is a critical need that needs to be addressed. I think a lot of people are familiar with the 2015 Protecting Our Infants Act. This is a federal response to babies exposed to opioids and neonatal abstinence, that there needs to be annual review of best practices and dissemination of information for this population. The Comprehensive Addiction Recovery Act 2016 helped ensure that these babies have a safe environment. Some states were penalizing and punishing women with opioid use in pregnancy, and this was having a negative effect where they were not getting prenatal care. They were having their babies on doorsteps in cars, avoiding going to the hospital because they were in fear of getting their baby taken away from them. And then the Support for Patient and Communities Acts, ensuring that Medicaid has funding to help these patient populations. And the Support Act in 2018 is looking for additional funding for prenatal substance exposure. And the Family First Prevention Service Act of 2018 provides additional funding for any programs, studies that are looking at how to support families, keep them together, decrease the use of child protective services, keep these babies with their families and out of foster care. Here we are in 2023. There's still a lot of gaps in the public health policy. Another issue is, despite all of these policies, in a review of states, only 60% of states said they were actually going to use this extra funding to change programs. So there's definitely gaps right now. So 50% or more than 50% of babies that are exposed to opioids in pregnancy are going to have withdrawal symptoms. But half of these babies can be treated with non-pharmacological measures, meaning there's support measures you can do that they do not need to be on medication and they can stay with their families. And that's over half of these babies. What's really interesting, the first baby that I took care of was in 1995 in a pediatric hospital. Behind the pediatric hospital, we actually had a clinic, a program where the moms would stay for treatment, and they would come just behind this back door into the unit, the pediatric unit, and they'd be with their babies all day. So it was supporting them during their treatment and with the babies. Then we had this shift around 2001 where Instead of being in the pediatric areas, these babies were shifted toward the neonatal ICU. This coincides with the literature. From 2003 to 2012, there was a 413% increase in admissions to the NICU for babies with withdrawal. So fast forward to today, they're now seeing that the NICU is not the best place for these babies, and at all costs, it's better to keep these babies with their families. So there's even places have specific withdrawal units, or they're going back to the pediatric floor or supporting them in the postpartum period. Really important to reduce foster care placement, which just foster care alone is costing $1.9 billion annually. There was a research study that looked at what would the cost savings and estimates and quality adjusted life years be if we supported these babies and kept them with their families, and it would save $509 million and 12,000 quality adjusted life years. So if we can keep these babies with their families, that would be optimal. Unfortunately, across the US, there's a lack of standardization for the care of these babies. A study looked at policies and protocols of a large amount of US hospitals and found 90% of them have policies, 90 to 98% have policies on farm treatment, on medication, but less than 70% have treatment policies on non-farm, like supportive interventions to help these babies. The variation in care begins even with assessment. So from the 1970s, been using this tool called the Finnegan Neonatal Abstinence Scoring Tool. This is a generalized tool. You click on it based on symptoms and you get a score. If score is a certain amount, the baby gets a medication. There is a new tool and a new transition called Eat, Sleep, Console. This is an individualized approach. Is the baby eating, sleeping? Is the baby consoled? This has had successful results in a lot of hospitals, and a lot of hospitals are switching to this transition to keep the babies out of the NICU and with their families. The challenges with standardizing care and non-pharmacological care is there's not a lot of resources right now. I think everybody knows hospitals are very short-staffed. There's not help to put these policies together. And one of the biggest challenges reported in the literature is healthcare provider agreement. Everyone agreeing that this is the standard of care for this population. So quality initiatives are the best thing to standardize non-pharmacological care for these babies. Example, Yale New Haven reduced their length of stay from 23 days to 6 days by using the Eat Sleep Console and doing education with staff, a whole list of things that they did for their quality initiative. Not all hospitals have the resources to do quality initiatives, so there is state perinatal quality collaboratives. These are really interesting. It's where public health officials and hospitals and the community all come together to do best practices and quality initiatives. You can go to just Google your state. So I live in California. I'd put California Perinatal State Quality Collaborative, and it would tell me all the great things that are happening in my state and ways that I can get involved. So I highly recommend that. They have been successful in helping improve the non-pharmacological care in hospitals by making standards. What they have noticed is when they have gone back and done a reassessment of the programs that there's only a 60% adherence to the non-pharmacological care. So they start off doing non-pharmacological care, but when they're going back for follow-up, it's not happening. And then if you look at different state perinatal collaboratives and you look at their non-pharmacological care, it's all variable. So we're still lacking a standardized way of caring for these babies. So now we get to infant massage and NOWS. So infant massage for neonatal abstinence syndrome and infant massage for neonatal opioid syndrome is minimally researched. Majority of the research for babies and massage is actually in the preterm population. It has so many great benefits for our preemies in the NICU. There's fewer studies on newborns, and there is very little to none on infant massage in this population. When we look at massage in general, it is endorsed as a non-pharmacological treatment for pain, by the National Institute of Health, the FDA, the Center for Disease Control and Prevention, the Joint Commission, and the American College of Physicians. Nothing specific for pain management in babies. But I am happy to say the World Health Organization released new guidelines last year, and they do endorse infant massage for healthy newborns. So that is very exciting to see that globally it is a recommendation to provide infant massage to babies. So there's a variation in hospitals that there was a study that looked at, okay, what are the non-pharmacological interventions for these babies? And what they found is infant massage is only being used in 21% or less of both NICU and non-NICU settings in birthing hospitals. Although we know that infant massage is low cost, it's non-invasive, and there's no adverse effects. And again, there's really a big research gap for this population in infant massage. Oh, also my pictures are my niece when she was a baby. She's now 8. She's a model. So babies in neonatal opioid withdrawal syndrome go through a lot of symptoms that impact all their systems, right? The central nervous system, they're extremely irritable. They have high tone, the autonomic nervous system. They're sweating, they have tremors. Because of their hyperactivity, this impacts their sleep. They wake up a lot. They have poor sleep quality. Gastrointestinal, they may have diarrhea. They may be constipated. They have difficulty with feedings. With the new guidelines with clinical definition, they say the 5 most common symptoms for neonatal opioid withdrawal syndrome are mainly in the central nervous system, and these are tremors, increased muscle tone, excess crying, disturbed sleep, and GI dysfunction. So those are the 5 main symptoms when you're thinking about babies with opioid withdrawal. The care approach should be decreasing those withdrawal symptoms and supporting the families. Again, there's not really research for these babies, but when you look at infant massage research in general, infant massage lowers pain, it provides relaxation, it promotes sleep-wake states, it improves nutrition and growth. Also with these babies, they either have poor feeding, maybe meaning they're not taking all their adequate nutrition, and some of these babies have the opposite, where they're eating too much. So they do have a lot of feeding issues. We really need to support families. I think I was listening to the talks yesterday, and we were talking. Everyone was talking about secure attachment and bonding and nurturing, and how important that is at beginning at birth for our lifelong relationships. And we really want to prevent separation, especially in the postpartum period. We know in the postpartum period that the moms are in the most fragile state and their emotions are high, and so you can imagine how much more stressful and traumatic that is for a mom with the opioid use disorder. We know through research that infant massage improves bonding and attachment, it provides parental engagement, improves confidence. So what I really wanted to do with my study is we know that 20% of hospitals are using infant massage as a standard treatment for these babies. So what I wanted to find is, what did they do that was successful to make this happen, and what were the barriers so that I could inform for future public policy, healthcare providers, and state perinatal quality collaboratives to include not only infant massage, but looking at how can we make sure that the adherence for non-pharmacological care sticks. So reiterating, 2020, the new CDC reported that 80 newborns are born every day in the US. And as I said earlier, we know now that depends on the state. And it's utilizing too many of our health and care and community resources, and there's a lack of standardized care. I used a general qualitative study for my study. So a general qualitative study lets you not only look at people's feelings and experiences, but this type of study also lets you understand processes. And so my 2 research questions were looking at the standardization process as infant massage is a non-pharmacological standard of care, and looking at the provider's experience of using infant massage, both to inform public health and state quality initiatives. So a theoretical framework for this study was the normalization process theory. This was it's a social theory from 2009 to help you understand social action to making something standardized and implementing something. It has three main areas: experience, implementation, and standardization. It has four constructs. The interview protocols were all based on these constructs. And when I analyzed my data, I used all of these four constructs too, so that it was very grounded in theory. So coherence is looking at the experiences of infant massage, benefits, barriers, cognitive participation. Who are the main stakeholders to make this happen? Collective action. How do you implement and get this standardized? And reflexive monitoring. How do you fix things that aren't working well, and how do you work on adherence? And they also used Critlow and force field analysis. It's from the 1940s, and it's really well known for change management. But I used specifically the field theory so we could see the driving and restraining forces for making this successful. My data collection inclusion criteria was neonatal or pediatric healthcare providers. They had to work in a birthing hospital, and they had to use infant massage as standard of care for babies with NOWs. They also had to have more than 2 years experience. I used purposive and snowballing sampling. I posted a flyer on LinkedIn, Facebook, and Twitter. So I got all of my participants through social media. I actually had a completely different study design. I was going to look at 2 hospitals, but then the pandemic hit during my study, and I had to completely change my data collection. I ended up with 11 participants, 2 RNs, and 9 occupational therapists. The years experience range from 5 to 42 years. The interviews were 20 to 50 minutes. I used a tape a call to record those people that wanted to do a phone interview, and then Microsoft Teams. I also used that too. I did analytic memos and journaling, and then I have the participants review the transcripts. So I use the framework approach. This is an approach used by the government and public health to really understand qualitative data. And I put this onto a code book. I did hand coding, 172 pages. I highly recommend any researchers on here if you're doing qualitative study. I really found Atlas TI software very helpful. What it does is you put all of your documents in it, and it pulls the most frequent words. So example, it said individualized care 49 times, family-centered care 51 times, and non-pharmacological 82. These became my categories. Then I put these 3 words together for one of my themes. So family-centered, individualized, non-pharmacological care. It's very helpful for qualitative studies to also hand code, but then also use software. So I identified 6 themes in my study, which I'm going to go over each one right now. And then I identified, in addition, with the force field analysis, both driving and restraining forces. The qualitative software was also really helpful in this. There's a thing called word list and word cloud. It puts all of these words into a cloud, and it kind of shows you visually your driving and restraining forces. So it was really great and helpful to me in data analysis. So the first theme identified was participants said that babies withdrawing from NOWs are one of the more challenging populations because of their symptoms and because of the social aspects, right? They have problems with self-regulation, and then, like I said earlier, the feeding difficulties, they're hard to console. So these withdrawal symptoms get worse and worse, and then they get separated and get admitted to the NICU. A new finding I found in my study is 2 of the participants reported that when these babies are in the NICU for extended period of time, they feel that they start having learned behaviors. So they feel like it becomes part of their behavior profile where they're having these symptoms to try to get the attention of caregivers when they're separated from their family. So that is a new finding from my study. And then once they're in the, and then that is like a snowball effect, right? So then they're having more withdrawal symptoms. So then they get more medication. So then they're in the hospital longer, and then separated from family longer, and then foster care. So it's just kind of a vicious cycle. Something really important that came up in my study is that these babies really need a modified massage. All of the participants said this. One participant was even explaining how she felt for preterm babies that the massage was a positive touch and nurturing. But when babies are withdrawing and they're in that really acute phase of withdrawing, it has the opposite effect. It can have the opposite effect and be overstimulating. So what they all mentioned doing is modifying the massage and individualizing it to their needs. So very important to look at their cues. Are they able to self-regulate? Start off with containment holds. And one of the therapists said they usually start very slow with massage, and it usually takes them till the time of discharge before they can actually tolerate all of the strokes. So really individualizing to that baby. And then another one of the nurses reported, one day they might tolerate the full massage and then the next day they're not going to tolerate it. So very important. They all emphasize that understanding the cues and teaching parents how to understand their cues is very important for this population. So another theme was, what are the perceptions of benefits and barriers to infant massage? So the benefits categorized into comfort. So it helped the babies relax, self-regulation. The participants reported that babies were better able to self-regulate when they had infant massage. Tone and motor development. 2 of the participants stated that these babies, even after discharge and up to 6 months when they see them in follow-up clinics, have hypertone, and the babies that are massaged, that this really helps a lot with tone and motor development. Nutrition and feeding, they thought it helped them. One participant said it helped them with increasing the breastfeeding rates just because of the skin to skin is what they felt, and helping with the sleep-wake cycles. I've also put some quotes. I have this one. If they do wake, they're not transitioning to an immediate disorganized, hyper alert, or crying state. They kind of do come to those calm alert states. So really helping with that self-regulation. The next part is benefits to not only baby, but also the entire family. The number one benefit participants said of infant massage for babies with NOWs was bonding. Bonding with their child is a great benefit. It's probably the biggest one. It supports that secure attachment and provides that visual contact. The maternal benefits, there is documents of massage decreasing postpartum depression, and that was brought up by participants. And family benefits, whether it be dad, a partner, a sibling, it gives them all something to do of positive touch for the baby. So really supporting the whole family. There are barriers to infant massage. The number one barrier reported to infant massage being successful was the lack of family presence. And all of the participants said this, well, if the families aren't there, they can't perform the massage. So I asked more questions during the interviews to try to figure out, well, why aren't the families there, right? So if they're not there, why are they? Why aren't they there? So there are maternal barriers, and these were varied. One of them that I wasn't expecting to hear was, the doctor didn't tell me that this is what was going to happen to my baby. So the participant explained how this mom was, in treatment. She was getting methadone, and she thought that since she was getting treatment, taking the methadone, that her baby would be a healthy baby. No one had explained to her that her baby could have withdrawal, and they never explained a possible admission to the NICU. So she had these huge feelings of guilt, so she wouldn't come into the NICU. So I think understanding that the lack of family presence being there might, because they don't have the support, they didn't get the education, and they may have those feelings of guilt because they weren't aware that this was going to happen to their baby. It could also be that they are in treatment themselves. We have to remember that they also need treatment. They're trying to help themselves so they can help their baby and their other children. It could also be social determinants of health. They don't have transportation. One participant explained a mom had to drive 45 minutes to come, so she could only come every 2 days. And then she stopped coming because she started getting healthcare provider stigma. Why aren't you coming? You should be here every day. But she couldn't afford or have the time with their other kids to come the 45 minutes to drive. So this is where it's really important to involve social worker, case management, making sure the whole team is involved and understanding why this family is not here and providing the support that they need. Unfortunately, healthcare provider stigma is a barrier to families being at the bedside. They are still, participants report, being judged for misuse, and they are treated different than other families in the NICU. They also reported some have stigma towards infant massage, that not everyone is seeing it as a mainstream intervention. So work to be done on education on the benefits.
Dr. Perez, we have one question.
Oh.
What are some ways you would recommend us as instructors to provide AIM education to the parents in the NICU?
I'm sorry, I couldn't hear the question.
What are some ways you would recommend us as instructors to provide IM education to the parents in the NICU?
Oh, infant massage education
Yes.
to the NICU?
Yes.
So I'm a CEIM, and what I did for when I was working in the NICU with withdrawal babies, I set up sessions with the parents when I knew they were coming in, and I would start with explaining massage and show them how to do that and help them do it. I am a nurse, so I am able to touch the baby based on my nursing license. And I found every family was different. Sometimes they wanted to observe. I always had a doll, just like if you're teaching a class, and have them with the doll and then show them on the baby. A lot of repetitive education, and just scheduling that time with them when they're in the NICU. And what I did find with these moms is they were happy to come in and do it, and they felt like I'm doing something to calm my baby. It gave them a sense of empowerment. And I think it takes away some of those feelings of guilt. They're like, okay, I can help my baby through this. I'm helping my baby. So really, I think working with that specific family and scheduling when they can come in, that's what worked best for me. But participants in my study said that they would find time, have the nurse call them. If it was a therapist, they'd have the nurse call them when they were at the bedside and then teach it to them at that time. So it depends on, are you the nurse at the bedside taking care of the baby? If you're a therapist, then the nurse would call you when that family is present. I hope that answers the question. I have more information on that in a few slides too. Thank you. So there's some driving and restraining forces, right? Parents and caregivers have to be willing to provide it. Another thing I forgot to mention, a maternal barrier or even any caregiver barrier, these babies do have hypertone. So the parents are a little stressed to do the massage because they don't have a normal tone like other babies. They're going to be very hypertoned. So I think this is where it comes in, where early intervention beginning in the hospital with therapy team, working with the families on how to work on them with their increased tone is so important. And again, a driving force for success is making sure it's modified based on cues. Restraining forces, we talked about that. So this information really informs public health officials and QI initiatives on the many benefits of infant massage for both parents, families, and the baby. Oops, I got stuck. So the next theme is family-centered, individualized, non-pharmacological approach. This goes back to what I was just saying: parental competence, parental empowerment, engagement, and individualized care. I really like this quote from one of the nurses. I think as professionals, we need to think, kind of empower them and be that, maybe that change agent for them to see that they can do it. You know, they can take care of their babies. For the moms that I've worked with that we have done this, I feel like they seem like there's some sort of sense of relief in it. At least now they're providing comfort for their baby. In my own clinical practice, I never had any mom that was, you know, did not like have positive experience from doing infant massage. So we know family-centered, individualized, non-pharmacological approach is much better than a medical model of care. It increases bonding, it decreases long-term, improves long-term outcomes, and decreases that length of stay. One therapist pointed out that, with non-pharmacological, with medication, you have A or B medication, but with non-pharmacological care, you have all of these different tools that you can use. And one of the occupational therapists said, I think that the non-pharmacological really does address that long-term social, cognitive, emotional development the baby is going to need. So again, the very big importance of early intervention. I did also find in my research study that infant massage is used as part of a toolbox per se of a lot of different interventions. So it's not going to work solely by itself, but it's going to work with a variety of interventions. So going back to the question earlier, when you are teaching a parent infant massage for babies' withdrawal, you really need to also not only modify the massage, but also modify the environment. They need a quiet location, a low stimulation environment, reduce your noise in the area, reduce the lighting, make the environment calm and quiet before you try to start the massage. This will help calm the baby, also help calm the caregiver, right? Next, families, we want to make sure that they are rooming in with their baby as much as possible, preventing separation. And we know for development, we need to provide all the opportunities possible for families to talk, read, sing to their baby. They need that facial recognition connection. They need to hear the voices. Thinking of all the sensory integration that was talked about yesterday, and the importance of the power of skin to skin. We know that that is one of the most powerful developmental interventions possible. Some interesting things in the study reported for comfort. Prefer vertical rock. Babies actually with withdrawal and prefer a vertical rocking position. And then when you are swaddling them, you want to use more of that, participants, the more of the stretching material versus the traditional like cloth blankets. You're not going to be able to get them swaddled and contained. Providing the scent of the mother. So having something where the baby can smell the scent of the mother is a form of comfort for these babies. All the participants reported sometimes the infant massage session is just those containment holds. It's still a form of infant massage, right? It's that positive touch. And then swaddle bathing. So that's the most developmentally appropriate type of bath.
So I wanted to piggyback on that because we had a question because there's so many barriers to infant massage or the babies in the NICU, tubes, etc. Which strokes do you commonly teach? Is there a stroke routine that's specific to these families? And so you listening, you just said the containment hold is sometimes the best one.
Mm-hmm. I typically, in my own clinical practice, not from my study, I use the containment hold always to start, and I listen to the baby cues. I think I can give you a great example, a case study that might put this all into perspective. I had a baby with withdrawal. I was the nurse. Fortunately, at the time, mom was not present. There was no family present. There was no visitors for this baby. Luckily, the situation changed later, but there was no one there. And he had really high withdrawal symptoms, really high scores, and he just only tolerated containment hold. And then the next week, I was taking care of him, and I'm like, I have him swaddled with his pacifier, and I'm like, let me try his leg. He let me massage one leg, and then I saw his cues, and he wasn't liking it anymore, so I went back to touch containment hold.
Mm-hmm.
And then a few weeks later, I don't know why he liked his one leg massage, whatever. I'm massaging his leg and his other leg just starts kicking, and I'm like, oh, you're ready for both your legs.
I'm ready.
Okay.
This leg's ready over here. It's jealous.
Yeah. And I think in that moment, I almost cried because I understand, I've been a nurse for decades and I understand the power of touch. But it was in that moment, I'm like, he can't talk, obviously, but he just communicated with me.
Mm-hmm.
and just said, "Hey, I'm ready for you to massage my other leg." And then that to me was where I understand how important this is for families to do, because I also forgot to mention that these babies actually don't respond to their caregivers in a normal way that healthy babies do. So
Oh,
it's even harder for the moms to understand their cues. So um, it really like showed me the power of infant massage, but I also have similar experience as what was reported in my study, that you really need a modified approach for these babies and just always watching their cues. So I would say the first thing you should, training them is containment holds and just cues and just the environment in general. So
thank you.
I can go on forever about this, right? And then we all know breastfeeding is optimal for these babies, or small frequent feeding, or on demand. It's like all over, because again, this is very individualized. No baby is the same. And non-nutritive suck. So I typically, for my own clinical practice, when I was taking care of these babies, swaddle the baby's pacifier, quiet, calm environment, start with the touch containment holds, and then I would see how the baby's doing depending on how much strokes. Yeah, I wouldn't say there's specific strokes. It's really going to be cue based. And then we look at therapeutic modalities. So infant massage is considered a therapeutic modality. Another one that's used a lot with infant massage, as reported by the therapists in the study, was they also use hydrotherapy and infant massage together, and they found that that's a really great combination. Um, Interesting, even for music for these babies, they need a quiet rhythm and pitch, typically lullabies or nursery rhymes, and only 2 or 3 chords. So very specific type of music for these babies. So something to think about and teach the families. What else I found interesting is all the participants reported they use the white noise that works the best for this babies is the shushing sound. So that's like shh, shh, shh. And there's actually devices now that they have in some NICUs where you press it and it provides the shushing sound. So shh, shh, shh seems to work really well for these babies. Very interesting finding in the study. Range of motion, and some therapists report using aromatherapy as part of their treatment, such as lavender. Frozen over here. Uh-oh. So really important that we provide non-pharmacological care. We move away from a medical model of care, and we include families. We talked about protecting our infants acts allows for funding for supporting families. So perhaps down the road, this will be an inclusion in that. The next one was, what really drives change to have infant massage in your unit? And one of the things everyone said, you have to have a core certified team. So you have to have a team that is certified and trained in infant massage to make it successful in the unit. And this varied. Some places they were able to get, everything implemented in 1 year, and other places it took 6 years. What was interesting is the place that was 1 year was a large IDN interdelivery network that had like multiple NICUs over multiple states. And even though they had to get approval for all of those places, it took them 1 year. And then another place was just one single hospital center, took 6 years. So really like the organization and the process, I think that's where the state perinatal quality collaboratives can really help get it reduced to the standardizing care quicker than 6 years. Okay. The other barrier I want to mention is funding. The participants did say they did have some hard time getting funding to take this. So hopefully when everyone sees all the benefits of this, that will not be an issue going forward. So continuing education, the World Health Organization actually recommends that any type of training in the postpartum period be in both written and digital formats. The participants all reported having handouts. It was interesting. Everyone created their own based on their unit. Participants reported using videos, but they're moving away from that because no one has DVD players, and then you can't find the DVD and you can't find the DVD player. Two of the participants said they have moved towards digital platforms. So one was a website where the parents could log on and all of the information is there. Another therapist developed their own web app. So it's an app and it has all of the videos and all of the information that they can get just from their phone. And also using a QR code. So moving towards technology for education was something that came up in my study. And it also needs to be continual education for both staff and for both families. And it needs to begin on admission. So they recommend beginning on admission, you start the education, and it needs to continue because the goal is that all of these families are doing infant massage by the time that they discharge and they are comfortable with it. They also said establishing routine in the hospital. There was a few participants that worked in outpatient, and they said that if they started the routine in the hospital with infant massage, they were more likely to still be doing the massage when they were out back in the community. You also need buy-in from healthcare providers. Some of the participants said that the healthcare providers did not, want to incorporate infant massage, but then when they saw the therapist doing it and the benefits, then they were like, wow, this really works. And then the therapists were getting calls, hey, this baby needs massage. So I think seeing the buy-in is really helpful to them and giving case studies, establishing in hospital. I think we went over this. Another restraining force is when the nurses are certified. Right now, there's staffing ratios and a staffing crisis, so sometimes the nurses are not able to incorporate into their care. We know that these babies with NOWs have long-term implications. They have quadruple the rate of readmission for the first 8 years of life. They have behavioral issues in school, social issues, emotional issues. So early intervention is really key in helping them transition to home. Again, I went through a little bit of this variability in organizational and monitoring. One of the things that popped up really strongly in my study was for infant massage, for NOWs to be successful in birthing hospitals, there needs to be an automatic order. So having an automatic order, so this either it's an automatic therapy order and that's included in their services, or it's an automatic order for infant massage that really ensures that adherence. Remember we talked about earlier, there's not only like a 60% adherence, but they found when it's a protocol and it's an automatic order, there's adherence. What else I found interesting in my study is one participant said that they've now have automatic orders in postpartum. So if in postpartum there's a baby that's been exposed to opioids, they have an automatic order to see therapy. So I think that is amazing because the other therapist reported that they wish that there was an automatic order for therapy in postpartum because they're not able to see those babies until their withdrawal is so severe they can't console, they can't eat, and then they get transferred to the NICU. So really looking for automatic orders beginning in the postpartum period for the earliest intervention as possible. There's a lack of standardized feedback and modification. So once they implement infant massage, so some hospitals just walk around, how's it going for this patient? Or they talk about it in rounds. And then other hospitals use surveys. So really that's variable. Documentation was also variable. Everyone uses reported electronic medical records. But the participants said what was really helpful is they started with writing in their notes versus nursing notes or therapy notes, but not all the other disciplines can see that. And so what they did is they created smart phrases, and that really helps for future research studies and outcomes, because then you can just do audits and pull data from that smart phrase in the EMR. So creating smart phrases in EMR is really important. And then reimbursement varied. Some therapists billed as their productivity, some therapists billed as sensory integration, and some therapists billed as massage therapy. So just depend on the organization. And whoops, we're almost running out of time. I talk a little faster. So this is just a visualization of all of the processes that go into making this a success. You have to start with clinical benchmarking, look at other hospitals, develop a committee, write the policies, get hospital approvals, get funding, get everybody certified, automatic orders. Hopefully it starts in postpartum. You also have to have funding for supplies if you're going to use oil, health provider education, identify any barriers the family might be there, not be that we talked about earlier. Do one-on-one training, and you want to make sure they do return demonstration, and you want to make this continual education. And really, again, individualized massage, environmental considerations, use your whole toolbox, start the routine in the hospital so they're successful when they go home, and billing and documentation. One hospital also incorporated families in the documentation. I thought it was really cute. By the baby's bedside, they created a little calendar and they had stickers. And if the parents gave the baby massage, they put a little sticker on the calendar. So I think that's a great way to incorporate families. And then you also want to do continuous feedback, what's working, what's not, collaborate with the interprofessional team, and constantly review your policies and update them as needed. So we talked about all of these. So I did have some additional findings. One of the last question I asked if there's anything else they wanted to talk about for babies with withdrawal. A couple of the participants said that their hospitals are using the Eat Sleep Console and it's been really successful. But then other participants said that one participant said they came to work one day and they were doing Eat Sleep Console and it was a therapist and they didn't even know, there was no education, no one understood what it was, so it wasn't going well, and then that there was no families there. So this caused a problem. And then the other thing is from a society level for social change, this quote really kind of hones it in. I think as methadone and opioid addiction become less stigmatized and more a part of mental health or public health crisis, that there will be better care for these families, and we need to go to more non-pharmacological family-centered care. We need to reduce individual provider stigma, make sure the hospital policies are family-centered. There was a lot of, there still is problems because of COVID. Before COVID, families used to have other people they can bring with them for support. They used to be able to bring siblings. And then with COVID, all these changed and just hospitals are just now starting to lift some of these visitation restrictions. So that's really impeded family-centered care, kind of gone backwards. At the community level, people need to know what happens when opioids are taken during pregnancy, and moms that are getting treatment need to know that their baby can withdraw, and just transparency on what that might look like so they're prepared and have the support that they need. And that is the sum of my study. I did create a handout with the references in this talk if anyone needs it.
Thank you so much. I feel like we all learned a lot, and we have a couple people who have questions.
Okay.
So one person wanted to know the website you referenced, if that was available for the public to use.
Which website? Oh, about the app that was developed for teaching. Mm-hmm. No, that was like something that just the therapist had developed for her patients.
Okay.
But I can see if there's a way I can find it, and if I can get access to it, I will let the team know to get to the participants.
Yeah. And then the other question was, what does hydrotherapy and or swaddle bathing look like?
Oh, okay. So swaddle bathing, so typical bath for a baby is just put the baby in the water and they're like, ah. And it's not fun. Like, how do you want to start your life? Just like, how stressful. So I should have brought my doll over here. So you take your doll and swaddle in a blanket, just how you're swaddling a baby, and then you have your tub. And if you Google swaddle bathing, you're going to see so many videos and images. And then you immerse the baby into the tub slowly, still swaddled, and then you remove like one side and bathe the baby of the blanket the other side. So they're in the bath contained in a swaddle, and they will have the best bath. This was something that we've been doing in NICU as a developmental intervention, and over the last few years, it's really great. Hospitals are now implementing this postpartum for healthy babies. So it's not just NICU babies. My little model niece, she got a swaddle bath. My nephew got a swaddle bath. So swaddle bathing is like the best developmental bath for a baby. And hydrotherapy is a treatment by a certified neonatal therapist that they do as part of their treatment. So it's a therapy session in the bath. So that's something that has to be done by a trained neonatal therapist.
Okay. Someone wants to know where you are in California.
Oh, this is La Jolla.
There you go.
But I live in La Jolla, but I have a national job. So I live and work all over the United States. So.
Anyone else have any questions? People are saying great information. Thank you. Thank you. You were right on target. Someone said, I wish I knew this. Excellent presentation. So yeah. Oh, we have new comments. Thank you. Thank you. We're so blessed to have you as our speaker. So thank you for coming today.
Thank you.
And I'll be sure to email the slides that you've put together to all of the ticket holders so they can review the information. And we'll also have this on replay. So if anyone has any, wants to dive deeper in, they can rewatch it as well. So thank you so much. I appreciate you.